Now, it is my pleasure to introduce Dr. Flora Peyvandi. Dr. Peyvandi is a full professor of internal medicine at the University of Milan, Italy. She is the director of internal medicine, hemostasis and thrombosis unit of the IRCCS Maggiore Hospital and director of the Angelo Bianchi Bonomi. I hope I did it well. Well, I know a little bit Italy, like zero. She's also at Hemophilia and Thrombosis Center at Milan. Her research is focused on the investigation of the molecular mechanisms of coagulation disorders and on the immunogenicity of the coagulation products. She'll talk to us on in the next 25 minutes on the diagnosis and management of rare bleeding disorders. Prof. Peyvandi, the mic is yours.
Good evening to everyone. Thanks very much for your kind presentation. Actually, it's a kind of pain to have a presentation for Saudi friends from here and not being video and doing the Umrah with you. And I hope soon we can have a face-to-face meeting and I was just starting my talk regarding the rare bleeding disorder, and here just let's go to see the definition of rare bleeding disorder. The rare disorder are affecting 5 people in 10,000 of the general population usually. And this patient seems to be very low as the number. However, they require lots of attention for the multi-domain type of management of this patient, labs and clinician, different specialists that they have to work together. So few number, but lots of attention. However, in your area, I would say this type of patient are not very rare, and the numbers might sometimes be similar to hemophilia B because of the consanguinity of the population. I think the first action, which is very important to understand whether there is a national database. I remember few years ago when I came to Saudi Arabia, we had a discussion regarding the organization of a national registry. And recently I saw this paper that it seems there is still some problem with having a proper national registry. And according to the Ministry of Health, I saw that there are about 6,000 to 8,000 type of rare disorder, and 75% of these rare disorders are affecting children, and 30% of patients die before their 5th birthday. And 80% of rare disorders have identifiable genetic origin. And I think it would be extremely important then to really work in management of these patients. Let's go to look on the distribution of every single type of rare disorder regarding the data of World Federation of Hemophilia and our registry in Milan. And usually hemophilia A are affecting 1 case in 5,000 of boys that they are born. And rare disorders can be very, very variable between 1 case in 500,000 for factor 7 up to 1 in 3 million of general population, like factor 2 deficiency or factor 13 deficiency. And the annual global survey based on 115 national registry showed about 324,000 patients were affected with the rare disorder, and about half of them are affected with hemophilia. And recently, we've seen an increased number of rare disorders up to 10%. And that means we are improving in terms of identification and diagnosis of our patients. And if you look on the data, we can see that factor 7 is about 38% of this group, and factor 11 almost more or less similar, followed by factor 10, fibrinogen deficiency, which are 10%. And then we're going to go to more rare cases like factor 5, factor 13, and factor 2. However, as I said, the data that has been published by the group of Tarek showed recently that in Saudi Arabia, the factor V deficiency is about 26% of the population. And an additional interesting data is coming to the similarity of factor 8 and factor 9. Here, I think we need to understand whether really these numbers means that hemophilia A and B are similar, or because hemophilia B are less severe compared to hemophilia A, and that's the number of the affected patients are less. And even there, we need to look on the data for factor 7, also factor 5. You can see how different it is from the rest of the world. The type of the clinical manifestation in this patient are extremely variable. You have those patients that are similar to hemophilia and bleeding a lot, and you have those patients that they are bleeding mainly on the mucosal tract, and when there is a big surgery. And that's the time usually you can find the person to be affected with a rare disorder. In that region, also circumcision is one of the problems with the affected boys, and that's the time of the discovery of the rare defect. And for the women, delivery and labors is creating a lot of bleeding event. CNS bleeding is frequent in factor 10 and factor 7 deficiency, and GI bleeding is mainly in factor 10 deficiency patients. And women with afibrinogenemia and factor 13 deficiency could suffer a spontaneous and repeated type of abortion. I want to bring your attention to women with inherited bleeding disorders. The reason why I think these women need more attention, because their trouble is starting from a very early age on their life. When they have their first menstruation with the first menarche, up to every month having a problem of bleeding during the menstruation, and then during the pregnancy and remaining pregnant, and after during the delivery. And sometimes the women with coagulation disorder could have ovarian cyst bleeding, endometriosis, endometrial hyperplasia, polyps, and fibroids. And all this makes extremely difficult the life of these patients. And we have to consider the best marker that you can use is the level of ferritin or iron deficiency, anemia. So what I want to ask you, please, when you have a woman with rare disorder, definitely look for the CBC and ferritin level of these women. Because if they have a very low level of iron and ferritin, they could have very bad quality of life, and that could affect their social life at work, at school, at family, or everything. So I think the doctors, they're working in the area of the Middle East, should pay more attention to that aspect. And when a woman is coming to the observation, even of those physicians that they are not expert, they have to make a good differential diagnosis, because there could be gynecological abnormality, but it could be as well, as we've seen, hemostatic alteration, which needs the screening test for that with a good laboratory testing. But we have to know what type of test to do. And during the pregnancy, we know that fibrinogen, factor 7, 8, 10, and von Willebrand and pies, they are increasing. However, in some of the deficiency like factor 2, 5, and 9, there is no increase of the level, and sometimes you can also, for the consumption, having the decrease. So that means the women with this type of deficiency definitely do need to be protected by the infusion of the single concentrate or whatever product is available during the first 3 months of pregnancy and eventually during the delivery. Now, the key question is to understand how to make the diagnosis in those cases that we have the suspicion of the rare disorder, whether there is any association between the phenotype and clinical severity of the patient, and what is the best treatment in terms of acute, and who are those portions of the patient requiring prophylaxis, and what we have to do for the women and the girls. I don't think for this audience, I have to make an explanation of what are the tests that we can use for the diagnosis of the rare disorders, and mainly APTT, PT, and TT are solving the issue for the specific type of deficiency. However, their sensitivity is a matter of issue for the remaining amount of factor, and particularly for the minimum level for prophylaxis of the patients. However, you can have the patients with a factor 13 deficiency, and this type of tests are not enough, and you need to act differently. And the mixing study, of course, is important when you have a prolonged PT and APTT. And as I said, thrombin time is important for the fibrinogen deficiency. And here is the list of all activities that can be measured. There are two factors. A part of activity, you need to have also the amount of the protein by antigen level. And that's in the case of fibrinogen deficiency and prothrombin deficiency, because the presence of positive antigen could lead to the different type of diagnosis. Instead of afibrinogenemia, the patient could have dysfibrinogenemia, or in type 2 could be dysprothrombemia, and that pictures could be associated with a higher number of thromboses, and the type of treatment might differ. So to make a long story short, a part of the assays that I showed, you have to keep in mind that for fibrinogen assay, you need a Klaus assay. And for factor 13, I know that in the region, clot solubility assay is used, but that's not longer recommended and by the ISTH, and also because this assay is poorly standardized and is detecting only those patients with a severe type of deficiency. What about the gene mutation? Once we have identified the patient with a phenotype analysis, you have 3 sets of genes involved and which are encoding the proteins that are involved in rare breeding disorder. The first are genes that are coding fibrinogen factor 2, 5, 7, 10, 11, and 13. And the second group of patients are factor 5 and 8 deficiency, and the group of David Ginsberg made extremely important data 30 years ago almost, coming with 2 genes, MCFD2 and LMAN, who are responsible for the secretion of factor 5 and 8, so are responsible for the secretion pathway of these 2 proteins. And then you have the third group, which are vitamin K dependent factor deficiency, which are 2, 7, 9, 10 protein C and S. And you need to analyze the genes like GGCX and VKORC1, which encode enzyme who are involved in the post-translational modification and in vitamin K metabolism. How we make the gene analysis? In the last 40 years, we are working from 80s with the PCR and Sanger sequencing, which is a gold standard and is the best methods and simple interpretation of the data. However, if you want to look on more genes that could be involved in such a phenotype, now these days, most of the labs, they're going to the next genetic analysis or next generation sequencing analysis, which is less cost effective, less time consuming, and there is a high throughput method, and also you need much less DNA. But there are some troubles with this type of technology that you might need to have experts, bioinformatic, for understanding what are these variants, and then you need to check these variants with the Sanger sequencing. recently, there was lots of interesting data coming from public databases containing huge genomic data, and that type of information was very important for data mining and trying to increase the number of the gene mutation for every single coagulation factor. For example, our collaborative studies with Dr. Stefano Duga and Roxana Celta just came over recently with factor 11 and factor 5 deficiency, where they doubled the number of the gene mutation in these two genes. When we study the genetic mutation in the patient with rare disorder, we end up always with 5 to 10% without any gene mutation. And of course, in those groups, genome and exome analysis are very important. And it's also very important, this type of analysis, in the group of the patients where the phenotype is not really matched with the genotype. And you want to understand, for example, what is the correlation between the genotype and phenotype? Because we know that null mutation and large deletion and insertion are responsible for no presence of protein. However, the missense mutation could be very heterogeneous, and the phenotype could not be completely explained. And that's the reason you need really, by the next gene analysis, to understand more groups of the gene that interact together for the specific type of phenotype. Now, let's move about when we have the gene mutation, how is the correlation with the phenotype? To understanding that, we try to look the data on the mice models, and you can see for fibrinogen, factor 5 and 8, 11 and 13, the completely knockout mouse were compatible with the survivor in the adulthood and non-embryonic lethality. And not always this picture is also confirmed in the humans. And to understand better the amount of the factors that is necessary for the patients, we went through 3 years data collection system in Europe, 13 countries, and almost 500 patients. And we established a standardized way of clinical severity description, asymptomatic, grade 1, with minor bleed after trauma or drug ingestion, grade 2, spontaneous minor bleeding by bruising and ecchymosis, and other type of mucosal bleeding, and grade 3 with severe bleeding like CNS and GI bleeding. And here you can see there were 3 classes of deficiency, those excellent, like fibrinogen factor 10 and 13, where there was excellent correlation, no factor, and very severe clinical condition. For factor 5 and 7, there was not always like that, and correlation was weaker. And for factor 11, there was no correlation at all. And that's the reason why for factor 11, we need to understand a little bit more in the future. And there are further data that I don't have time to go through, but it seems also that fibrinolytic activity is different in factor 11 patients. And once all of this has been done, you do need to treat this patient. And that is the most difficult part, because in the last 20 years, there was lots of new product for hemophilia and not so much for rare disorders. First of all, you have to understand whatever product is available in your country is better to use the single factor concentrate. Secondly, make sure that is free of the virus infection, hepatitis C, hepatitis B, HIV, or any other type of contamination. And then we can go with the PCC and the last with the cryo and FFP if we do not have any other choices, but we have to make sure that are virus inactivated. Non-transfusional treatment like antifibrinolytic, fibrin glue, hormones, and desmopressin is very valuable type of product that can be used for especially mucosal type of bleeding. On-demand treatment could be very different from patients to patient because of the half-life of patients. Because of half-life of products. And prophylaxis is even more difficult. For prophylaxis, you do need to understand which portion of your patients really have severe type of clinical manifestation, and that are about 10%. Please do not wait for the cerebral bleeding to start the prophylaxis. Try to understand if in a family there is a severe bleeding. And in some of the deficiency, like factor 7, the prophylaxis is very difficult because you have to do it at least once a day or 2-3 times a week. For factor 13 is enough to make it only one every month. And that really changed the quality of life of the women, for example, for prevention of recurrent abortion. So this table is lots of information, but what I want to invite you, identify the patient, keep the levels around 20-30%, and make sure mainly that the product is safe. And don't forget about your women. Start with the hormonal therapy. Of course, if the woman is at the reproductive age, you cannot go with the surgery, endometrial ablation, or hysterectomy. Pay attention to that. Try to support these women with hormonal therapy and eventually with a substitutive therapy for few days a month when they want to keep the reproduction. Age of the woman, overall the health, medical history, and the cause and extent of menorrhagia, and also the tolerance for a specific medication and procedure and therapy is important. And don't forget the effect of menorrhagia and anemia in the style of life of your patient. And you know very well that in that region of the world, lots of women could have a problem of divorce and the problem of legal issue, and we need really to protect them. And we have to talk with all these women to understand their culture, their personal choice, and go for the best treatment for them. And with this one, I think I finished my presentation just to report that you need to make the protection of your women even during the pregnancy and during the childbirth, and trying in women with factor 13 deficiency and fibrinogenemia to protect them in the first 3 months. And at the end, novel therapeutic strategy like extended half-life products, anti-TFPI, emicizumab, small interference RNA, all these have been tested in hemophilia. And I think there are really good products for the future in rare bleeding disorder. And we need to make sure that the companies get interested in the rare disorder and maybe even the gene therapy, and try to make sure that you are creating your global or national partnership with the collection of the data, making better assays, and trying to bring the attention of the public health. And also, we need really understand better this group of heterogeneous rare bleeding disorder. And with this one, I want to thank you, and also thank all those people that are listening to this presentation who collaborated with me in the last 30 years for the collection of the data that I have shown.